Good morning. My name is Heather Cheng. I'm the director of the Seattle Cancer Care Alliance Prostate Cancer Genetics Clinic that's recently been launched. I'm also an assistant professor in medical oncology at the University of Washington, and I'm delighted to speak with you this morning about new discoveries in prostate cancer genetics. So here are my disclosures. The objectives this morning are first to understand the critical components of a thorough family cancer history, to understand the new updates regarding incidence of inherited cancer risk genes in the advanced prostate cancer population, and to appreciate the role of inherited cancer risk genes in the context of current prostate cancer screening guidelines, and finally to appreciate the role of inherited cancer risk genes in the context of treatment for prostate cancer. I'm going to start by sort of pointing out probably what most of you already know, which is that family history of cancer is well known to be a risk factor for cancer. And this is not just true for prostate cancer, but for other cancers such as breast cancer and colon cancer, for example. And many people already are very familiar and comfortable with the concept that having a father or a brother with prostate cancer doubles a man's risk of himself having prostate cancer. And many people are also similarly very familiar with the concept that having a mother or a sister with breast cancer can double a woman's risk of breast cancer. And what I'd like to emphasize to you today is that having a mother or sister with breast cancer, if you are a man, can actually affect a man's risk of prostate cancer. And I'll, in the course of this talk, hopefully show you data and convince you why that is the case. So some genes mutations confer a very high risk of cancer, where other genes confer a less high risk, and I'll explain that in a second. So we know that the risk of cancer can be comprised of a number of different components, including diet and lifestyle, environmental differences and risk factors, and then genes. And so I'm not going to talk today about diet or lifestyle or environment. I'll focus more on the genetics. And this slide is really to remind people or to point out that there are gene mutations that are very common in the population, meaning maybe every other person may have these variants, and they confer a low risk. So if you inherit certain mutations, you may only have an increase in your risk of 1.5-fold compared to somebody who doesn't. On the other hand, there are more rare variants, which are moderate penetrance, and then rare variants, which are high penetrance. And what that means is that these mutations in a population may be quite rare, but if you inherit them, they may actually result in a much higher risk of developing a condition such as, for example, breast cancer. So in breast cancer, which we've studied and understand a little bit more, there are certain rare variants or gene mutation which confer a very high risk of breast cancer, and these would result in differences in medical management, such as, for example, preventative surgery or different screening programs. So rare mutations in common cancers are still relatively common. So I just talked to you about how there are some mutations in certain genes that are rare. And this is just to point out that this is the 2017 estimated new cases of cancer from the American Cancer Society that just was published, I think, not very long ago at all, since it's the new year. The most common cancer, type of cancer that's estimated to be diagnosed is prostate cancer, which represents 19% of new diagnoses of cancer in men, and for women it's breast cancer. And you can see it's 250,000 here, 161,000 gone down a little bit, probably because of PSA screening changes. And this is even a rare mutation in prostate cancer may still approximate the cancers for example, more rare cancers such as oral cavity or pharynx cancer. Here are the estimated deaths. Prostate cancer is number 3, representing about 27,000 in a year. And so this is still pretty impactful, even though these are mutations that may be less common in a population. Here is the family tree. Many of you may be familiar with looking at these or not. This is also called the pedigree. This orange arrow is the person who is sitting in front of you in clinic, or the proband. And in this case, the circle is a female and squares are men. And this is two siblings. Their mother had breast cancer at age 42. There's a cousin. These are siblings. Here are siblings of the mother. So this is a maternal aunt, a maternal uncle, a maternal aunt who was diagnosed with ovarian cancer at 53, and another maternal aunt who was unaffected. And here is the maternal cousin who was diagnosed with breast cancer at 38. The maternal grandmother also was diagnosed with ovarian cancer at age 49. So this family tree or pedigree is representative actually of a family that has a BRCA1 mutation. So it turned out that after the fact we learned that this woman did have a harmful or pathogenic mutation in BRCA1, which is a rare mutation that confers a high risk of breast cancer. Many of you may be more familiar in thinking about BRCA1. And so we know, and I'm going to get back to prostate cancer first, so bear with me for a second, that there is an increased risk of breast and ovarian cancers as a consequence of inheriting BRCA1 mutations or BRCA2 mutations. And these, again, are single genes that are associated with a significantly increased risk of cancer development. So in other words, people who inherit a harmfully mutated or pathogenic BRCA1 or BRCA2 gene have a lifetime risk of breast and ovarian cancer that can range between 45 to 60%, or ovarian cancer between 20 and 40%. The exact percentages may vary on the exact mutation, but generally we recognize these genes, certain mutations, to cause an increased risk of cancer. And these, again, can vary based on the details of the family history as well as the mutation. Many of you are very familiar and may have heard in the news a few years back, Angelina Jolie put out several editorials in the New York Times describing what she did to help reduce her cancer risk. She has one of these gene mutations, so BRCA1 and 2 carriers who don't have cancer do have options for different cancer screening as well as risk reduction. And she described those, and I would recommend reading those editorials, which were fairly, well thought out, and I think important in raising awareness. So women who inherit BRCA1 and 2 gene mutations have options for considering lifestyle changes, screening, cancer screening modifications. There are certain medications that can be used for prevention of cancer, as well as preventative surgery, prophylactic surgery, as well as treatment options. So I'm going to talk briefly about this concept called synthetic lethality, which is something that's very pertinent to women, they were first discovered in the context of breast and ovarian cancer with BRCA mutations. And this is essentially how to selectively stop BRCA mutated cancers. And so this is like an Achilles heel for cancers associated with BRCA mutations. And this is my kind of simplified way of thinking about it. If you understand that all cells are dividing rapidly, normal cells and non-cancer cells, in dividing there can be mistakes that are made. And so the body has developed systems, quite elaborate systems, to ensure that mistakes don't get propagated, that they get discovered, they get corrected, and so they're sort of editors and spell checkers, so to speak. So if you consider BRCA mutations or genes responsible for example, correcting certain types of mistakes, let's say they're serving as a function of the copy editor, and this is, in this case, a function called homologous recombination. There's another pathway that also does a different type of editing function, and let's call those PARPs, or poly-ADP polymerase, these, let's say they're spell checkers. This is a different type of DNA repair called base excision repair. The details are not quite as important as the general concept in this case. So when there is damage to the DNA, let's say single-stranded break, PARP inhibitor, or PARPs, can repair base excision. If you inhibit this specific type of DNA repair, then there's a backup, and so the cell will then move to a different editing function. In this case, it would be the homologous recombination repair pathway would take over. Let's say your copy editor would take the place of a defective spell checker on your computer, and you would be able to compensate, correct your mistakes, and proceed with cell division and maintenance of your DNA, and the blueprints would be preserved. If you take both of these out, and so cancers that develop in patients who have inherited a germline mutation or inherited a BRCA mutation that doesn't allow it to work properly, then they're especially sensitive to inhibitors of this second pathway because they're really reliant on them. So healthy cells that don't have BRCA deficiency can compensate just fine, even when you inhibit this PARP enzyme, but cells that have a defect or deficiency or mutation in BRCA2 cannot compensate. And so this results in tumor or cancer selective cell death, which is also called synthetic lethality. So I'm now finally getting back to prostate cancer. What we've recognized recently is that, well, actually this has been known for some time, is that BRCA2 mutations affect the risk of prostate cancer. So here is a pedigree of a family that involves actually a man who developed breast cancer at 52, but there's also other cancers in the family, including breast, pancreatic, ovarian, and prostate cancer. We've known for some time that BRCA2 carriers in men have a 5 to 9-fold increased risk of prostate cancer, and we think that BRCA1 carriers have a 3-fold increase in risk of prostate cancer. So although these genes are recognized for their association with breast and ovarian cancer predominantly, they also really affect the men in the families who are at risk for prostate cancer. We also know that BRCA2 mutation carriers who develop prostate cancer fare worse, even when they're offered curative intent treatment. So this is data from the UK, where they have a cohort of families that have breast BRCA1 mutations and BRCA2 mutations, and this is really Kaplan-Meier curves to show that the overall survival of BRCA2 mutation carriers in the black line is worse than those who don't carry BRCA1 or BRCA2 mutations. In this graph, the yellow represents the BRCA1 carriers. There were not enough of them to really show statistical significance, but it's clear that BRCA2 mutations do worse. On the right-hand side is metastasis-free survival despite curative intent treatments such as surgery or radiation. And again, BRCA2 mutation carriers do have worse metastasis-free survival compared to those who don't carry those same mutations. So we know that prostate cancer outcomes are worse for men who carry BRCA2 mutations and probably BRCA1 mutation, but we haven't systematically been looking for these patients or these men. And so one question is, well, how do we find them, and how can we recognize that they have a risk for these mutations, and can we do something differently about them in the same way that we do for breast and ovarian cancer? So here is actually one of my own patients, patient M, who had a family history of prostate cancer. This is him. He had 4 brothers and a sister. This was his family history if you ask about prostate cancer. So frequently I see patients referred to me who in their medical records will say, well, this patient has no family history of prostate cancer. While that's important information, it's not sufficient. So he does not really have any family history of prostate cancer, as you can see. He himself was diagnosed with prostate cancer at age 58. But if you ask the question a little differently, you get more information. So if you ask him about all cancers, this is what you find. He had a sister who died of breast cancer at age 35. That's quite young. And you'll see 2 of his brothers died in car accidents. His mother actually died at 33 of breast cancer, and his maternal grandmother also died of breast cancer. So once we recognized this, we sent this family for genetic testing, and it turns out that the family has BRCA2 in the family members who were affected, but also in one of the brothers. We didn't test him, but he was an obligate carrier. We knew he must be a carrier because his children, one of his daughters, had this mutation, the BRCA2 mutation. So my patient here, the 58-year-old, or the patient with prostate cancer at 58, was found to have a BRCA2 mutation, and this was important for his management and care for his prostate cancer. But the other benefit of this, which had not been previously recognized, at least in this family, is that we were able to refer his daughter for breast and ovarian cancer prevention at our clinic. We have a clinic to discuss prevention options for women who have these mutations. She had a risk-reducing oophorectomy. And also the nephews. So there are nephews who they haven't been tested yet, but that would be potentially at risk also for inheriting the BRCA2 mutation, and that might increase their risk for prostate cancer as well as their risk for more aggressive prostate cancer. So this is the collateral benefit of doing a thorough family history and really recognizing the connection between BRCA1 and 2 and some newer genes that I'm going to talk about and prostate cancer, and not just focusing on women, but recognizing that these gene mutations are important for men as well. What is a complete family history? So I think it's really important to ask about both sides of the family, both the mother's side of the family and the father's side of the family, to ask about all cancers, not just prostate cancer or genitourinary cancers, to ask about the age of onset. If you don't know for sure, even approximate decade can give you some information. What kind of treatments might have been given if you know that, and if that relative died from cancer. So, as you know, prostate cancer is very common, and most men may be diagnosed with relatively indolent or non-aggressive prostate cancer, and that's very different from having having a male, let's say an uncle diagnosed with prostate cancer and in his late 80s of Gleason 6 prostate cancer is very different from having a brother who died of prostate cancer in his 60s. The degree of aggressiveness can be really important, especially since screening has uncovered more of the less aggressive types of prostate cancer. We still know that there are some prostate cancers that are quite aggressive and can be lethal. And a final question when you're asking about the family history would be if there is indication of someone in the family who was diagnosed very young with aggressive disease, and in particular a cancer type that might be recognized to be associated with the cancer risk syndrome or cancer predisposition syndrome, was there any genetic testing done, and do you know those results? So these are all important aspects to ask about, and if you feel as though there's guidelines available in the NCCN and very up to date and various resources. If you think that there's a suspicion that there are enough members of the family to cause you to think that this might be present, then it's worth thinking about referral to genetic counseling for further discussion. So here's when to refer. We just talked about that. If you're not sure, you can always pick up the phone and call and see, does this seem like a reasonable referral? So I'm going to shift gears now and talk about some additional new research updates, and hopefully you'll recognize the relevance to what I just talked to you about in the earlier part of the talk. What I'm going to talk to you now about is how common are mutations in genes such as BRCA2 in prostate cancer, and these are germline and inherited mutations versus genes that develop mutations only in the tumor itself. Those are acquired. Those would not be inherited. So there are two different flavors of genes that might be important, and I'm going to focus on the germline and inherited component. How do we best identify BRCA2 mutation carriers in the context of prostate cancer? And then I'm going to share with you some exciting new developments in treatment approaches for prostate cancer in the context of these mutations, and understanding how we can start to learn about even some newer prostate cancer risk genes that have not previously been recognized. So this is work that was reported in 2015. This is in a study that was done with a multi-institutional collaboration, and really the purpose of this, and it was sponsored through the Prostate Cancer Foundation and Stand Up to Cancer philanthropic organizations, but the objective of this was to study advanced or metastatic prostate cancer. So recognizing that prostate cancer is common, many prostate cancers are not aggressive, this study set out to really understand aggressive, lethal metastatic prostate cancer, when it's very advanced, very aggressive. So we selected men, and we at the University of Washington and Seattle Cancer Care Alliance and Fred Hutch participated in this really landmark study, and it was to look at metastatic biopsies of men with metastatic prostate cancer and to sequence them in a way that we could understand the mutational landscape of these aggressive type prostate cancers. And we reported in the journal Cell in 2015 the first 150 cases. This study is still ongoing, but the results of these were quite remarkable, because previously we had based our understanding of prostate cancer mutations on prostatectomies or the primary prostate cancer, rather than later in the disease course when there might be more aggressive features developing. And this is really to try to understand how can we treat advanced aggressive prostate cancer better. So the results of that showed that there were 5 major pathways, and others as well, but these were the 5 major pathways that had mutations that were identified. There's a Wnt pathway, PI3 kinase pathway, androgen receptor pathway, androgen being testosterone, the testosterone pathway, and cell cycle, and then finally DNA repair. So I'm not going to talk about these other 4. DNA repair really are these same genes that we've been talking about this morning, BRCA1, BRCA2, and then some others that are in that same family with the same function. So again, the molecular landscape of metastatic prostate cancer, when we look at the metastatic or the late stages of prostate cancer, we found actually that almost 1 in 4, 1 in 5, 20 to 25% of those cancers had mutations in DNA repair. And what was even more surprising was that about 8% of them were inherited of the 150. So this was quite different than what we had previously believed or known to be recognized to be true. And this was very surprising, because people understood that prostate cancer was inherited, but we really didn't think that these rare high penetrance mutations comprised most of the risk. And we were surprised, and this was quite interesting to the entire field. Of course, whenever we find something, we want to validate it, and so there was a follow-up study, which I'll get to in a second, but I'll tell you a little bit more about the genetics of prostate cancer. We've known for a long time that prostate cancer is one of the most heritable cancers, and we know that about 50% of inter-individual variation in risk is accounted for by genetic factors. And we've also known for some time that mutations in BRCA1, BRCA2, MSH2, and HOXB13 account for a very small proportion. So people estimated, the prior studies and estimated less than, around 1 to 2% at most, representing these mutations in these genes as part of the genetic components of prostate cancer. And again, 1.2 to 8% of prostate cancer overall. And so the follow-up study to the Stand Up to Cancer or metastatic landscape study that I just described was this. And this was reported this past summer, or July 2016, in the New England Journal of Medicine, Pritchard et al. This study was the follow-up validation study, and in this study we looked at approximately 700 men with metastatic prostate cancer from 8 institutions internationally. They were not selected for family history of cancer or their age of diagnosis, even though you might think that there would be an association with the family history. This was an unselected population. And for each of these patients, they underwent multiplex sequencing to assess for inherited or germline mutation in 20 different DNA repair genes. And here are the results of that study. We actually identified that of the almost 700 patients, almost 12% of them, 11.8%, had deleterious or pathogenic or inactivating germline mutations, inherited mutations in 16 different DNA repair genes. Not surprisingly, we see here again BRCA2, but some newer genes that we haven't previously recognized to be associated with prostate cancer risk. Genes like ATM, CHEK2, BRCA1, PALB2, and I mentioned earlier MSH2 and MSH6. Those are associated with Lynch syndrome and were represented in the 1% of that group. So really the point is to say almost 12% of men with metastatic disease, regardless of their family history and regardless of their age of onset, had inherited gene mutations that could affect their treatment course, but also have important implications for their family members. So to re-emphasize the findings and implications, the prevalence of heritable or germline DNA repair gene mutations in men with metastatic prostate cancer is upwards of 11%. And this is much, much higher than we previously thought. So this is really important, and I think going to be practice changing. This suggests, because of this high percentage, that all men with metastatic prostate cancer should be considered for genetic testing, regardless of their age of onset or their family history, just because of the high prevalence. Germline DNA repair mutations identify families that are at risk for autosomal dominant cancer predisposition syndromes. So these men may be the first in their families to indicate that there may be a genetic component, and maybe other members of the family could benefit in terms of their screening and understanding their own risks of other cancers. Germline DNA repair gene mutations also have implications for cancer treatment selection. So I talked earlier about PARP inhibitors in the context of breast cancer and ovarian cancer. We're now very excited about looking at these same treatment strategies in prostate cancer, and I'm going to talk about that in a second, as well as platinum chemotherapy. And there are a number of clinical trials that are coming for patients with prostate cancer and who have mutations in this gene family. So here is a paper that came out in the New England Journal of Medicine in October of 2015, a couple years back now, or over a year ago. And this is looking at olaparib, which is one of the PARP inhibitors, in patients with DNA repair defects in metastatic prostate cancer. So this study was also very, very exciting, came out about the same time as the recognition that DNA repair is highly mutated in metastatic prostate cancer. And this paper showed that there were 16 patients who had both metastatic castration-resistant prostate cancer, which is a late stage of prostate cancer, as well as genetic defects in DNA repair. And 88% of them had a dramatic response to the PARP inhibitor olaparib. In the oncology world, or in prostate cancer, 88% response is tremendous. And this really speaks to the fact that the more we can understand the biology of cancer and the specific, unique genetic defects of a given cancer, a given person's cancer, the better we are able to treat it. In the past, we've lumped people together in terms of their treatment selection, and now we have the ability to start more precisely treating them and choosing their treatment selection based on their mutations in their cancer. This has been true across the board in many different types of cancer, and this is probably the first real example in prostate cancer of this being the case, and it's very exciting for patients and for physicians as well. So here is the paper that we published, or our group, to describe platinum chemotherapy effectiveness in BRCA mutated metastatic castration-resistant prostate cancer. In this study, this was a retrospective case series. There were 3 patients who had an exceptional response to platinum chemotherapy for prostate cancer, which I should point out is not a commonly used chemotherapy for prostate cancer. It's not typically selected because we haven't, in larger studies, has not been as effective. But there were 3 patients who had an exceptional response, and we went back and we sequenced their cancers, and we found that all of them had biallelic, or both copies inactivated of their BRCA2 genes in the cancer itself. 2 out of the 3 of them had germline or inherited BRCA2 mutations, one in a man who had no family history of cancer. So I'll show that data to you here in another form. This is the first patient. This is his PSA graph. He had had a number of other treatments for prostate cancer, including docetaxel, abiraterone, and enzalutamide. These are some of our newer agents. He developed liver metastases here at the time in 2012 when his PSA was really starting to rise into the 500s. He was started on carboplatin, which is a platinum chemotherapy, as well as docetaxel, which he had previously been refractory to. And you can see that he had about 18 months of response. He was treated here and then went on a chemotherapy holiday. And then once his PSA started rising, he was treated again with very good effect. 18 months in the setting of this number of prior therapies is quite remarkable. The second patient also had a PSA that was rising despite abiraterone and enzalutamide, and in 2015 he also had docetaxel, and when he was treated with the platinum, again you can see his PSA declined quite dramatically. And the third patient had a very similar story, except to say that he had 30 months of response to platinum chemotherapy. We found both copies of BRCA2 mutation, the BRCA2 gene mutated, and in 2 of them there was inherited or germline BRCA2 mutation. And here are the pedigrees, and you can see there really isn't a compelling family history to suggest that they may have had this if we had not been looking. So exceptional response to platinum chemotherapy was associated with biallelic or both copy inactivation of BRCA2. And the point to make is really that family history is critically important to collect, especially for primary care, internal medicine physicians. In the oncology world, we know that will miss some of the germline carriers and all of the somatic only carriers, meaning the people who have these mutations only in the cancer for which it's not inherited. So positive family history increases the probability of carrying an inherited cancer risk gene, but does not rule it out. And so it's helpful and critical information to collect, but there may be more to the story. As well, early age of onset is also important and should trigger you to consider thinking about genetics, but usual age of onset, or in other words, people who, for example, are diagnosed in their mid to late 60s, would still potentially have an inherited cancer risk mutation, and this would be important for their families and again also for their own treatment for prostate cancer. Here's the pilot study that we are conducting at present. Actually, this is I apologize, this reference does not apply. Here's the reference for this clinical trial. This is the study of docetaxel and carboplatin for treatment of patients with late-stage prostate cancer that has inactivation of the BRCA1 and 2 genes or other genes in that pathway. And this is basically looking to combine docetaxel and carboplatin, and we are looking at the rate of PSA decline from baseline, as well as some correlative studies as well, such as the response duration, time to radiographic progression, and we are also looking at tumor mutations in circulating tumor cells as well as circulating tumor DNA. And so this is an exciting study. It is ongoing at the University of Washington and Seattle Cancer Care Alliance. There are also many other trials coming, including those incorporating PARP inhibitors as well. So I want to return back to this point that I made earlier, which is that BRCA2 mutations affect the risk of prostate cancer. This is the pedigree I showed you earlier to say that we know that BRCA2 mutation carriers have a higher risk of prostate cancer. BRCA1 mutations also, in this case 5 to 9%, in BRCA1 approximately threefold. Remember that this data is collected from families that were recognized due largely from breast and ovarian cancer. So there may also be some families that have a predominance of prostate cancer over breast and ovarian cancer, and so we have more to learn about these genes. One of the interesting things that I've really begun to think a lot about recently is that I'm a medical oncologist. I treat patients with metastatic disease with the treatments I just talked to you about. I'm quite excited about those, and as is the field. But when we think about the family members or the sons and the nephews and the brothers of our patients, we want to think about how we can help them, how we can prevent this from happening. And so I've been doing a lot of thinking about the prostate cancer screening guidelines for higher risk men. This is for higher risk men, not average risk men. For example, men who have a relative that has advanced prostate cancer are unclear at best. So I don't need to tell you about the controversies in prostate cancer screening, but for high-risk men, these are the current recommendations that I could find as of a few weeks ago. So the American Urological Society says that for early detection or screening strategies, African American men or men with a positive family history of cancer should be individualized, but doesn't really give us much more specifics than that. The National Comprehensive Cancer Network also says that it's important to collect a family history and ask about BRCA1 and 2 mutation in the family. But there's no specific changes or guidelines to screening or PSA even for men who have BRCA2 mutations. The USPSTF, of course, at present does not recommend PSA screening, but doesn't really account for men who have higher risk. So if you have a BRCA2 mutation and you have a positive family history of, let's say, lethal prostate cancer, I don't think that man would have average risk for prostate cancer, and I would think that might be somebody who maybe should be getting screened differently. The American Cancer Society put their latest recommendations out in 2016, and I think they probably do the furthest or do the most, but still I think we could use more clarification here. So their recommendation is that for high-risk men who are African American descent or have one first-degree relative, meaning a father or a brother, with prostate cancer at an early age, to start screening at 45. If you have very high risk, for example, more than one first-degree relative with prostate cancer at an early age, they recommend starting at 40. So you can see there's the field as a whole really should be giving this more thought, and my hope is that in the years to come we will have more data and better guidelines to advise how we should consider men who are at increased risk for prostate cancer and how their screening and early detection strategies should be modified accordingly. Here is a study that we're going to have soon, opening at the University of Washington in collaboration with the University of Michigan. This is a targeted early detection program in men at high genetic risk for prostate cancer. This study is looking specifically for people who have genes such as BRCA1, BRCA2, P53, which is Li-Fraumeni syndrome or Lynch syndrome. So the study population is to recruit men who don't have prostate cancer, who are at risk for prostate cancer, to screen them with this different protocol so we can collect their data. They'll also have urine and blood collection, and we'll run some newer novel cancer biomarker tests to see if we can increase sensitivity and specificity. So this, I hope, is going to be the future, that we're going to have more clinical trial options, but certainly more data and more information to guide how we should be looking for cancer in men who are at high genetic risk. In the meantime, we have to take care of our patients somehow. This is what I generally say, and I do acknowledge that this is pending higher level evidence. But from a practical standpoint, I think what I tell my patients for their sons, nephews, and brothers, my patients being those who have metastatic prostate cancer, is to encourage them, their relatives, to be very familiar with their family history, to know the things that we talked about, who in their family was affected, how old did they have their diagnosis, what treatments might they have gotten, and really to be proactive in sharing that with their doctors. I would recommend considering a baseline PSA and a digital rectal exam at age 40, and compare that with age-matched controls, and if elevated, to consider rechecking it yearly. If someone tries to talk them out of PSA screening, I generally recommend that they find a doctor who will at least discuss and consider the fact that they are at high risk with them, and to recheck guidelines periodically, because I think in the near future we will have hopefully additional recommendations and guidelines that are specifically geared towards men at higher genetic risk. and if at all possible, to enroll in a screening trial or registry so that we can collectively learn more about how we can treat and screen for prostate cancer in the context of inherited cancer risk mutation. So there's a rapidly changing landscape of prostate cancer genetics. I told you earlier that approximately 25% of patients with metastatic prostate cancer have mutations in DNA repair genes that we currently recognize. So these are genes like BRCA2, ATM, BRCA1, and others. These mutations likely predict sensitivity to platinum chemotherapy and PARP inhibitors. About 11% of metastatic prostate cancer patients have heritable or germline mutation in DNA repair genes that are also recognized as familial cancer risk genes. So 10% or over 10% of men with metastatic prostate cancer carry germline or inherited mutation that directly affect their cancer treatment options and have implications for prostate or for their family members. There are a number of barriers to the incorporation of these new findings to clinical care, which I recognize and I just want to point out to you. This is changing quickly, so I hope that this will not be true for very long. But at present, prostate cancer clinicians are getting familiar with cancer genetics. I think that's going to change pretty quickly. We're recognizing the importance of this. We're getting more familiar with this, and we're hopefully going to attend to this in our practice. But lack of recognition by providers is really a problem. So not asking about non-prostate cancers in the family is a low-hanging fruit, is something we can all go out and do today. We can change our practice by asking those questions a little more thoroughly. There is a recognized shortage of genetic counselors, so that will be a challenge. And at present, there are insurance barriers for coverage of genetic testing for prostate cancer. If there is a family history of breast and ovarian cancer, we can often get that covered by insurance. But if the family history is significant only for prostate cancer, or if a man just has metastatic disease, we sometimes can run into difficulties. That's not to say we shouldn't try, but this is something that I hope will be rectified in the near future as we collect more data and show why that's important. Finally, there's a very common misconception, probably historic, that many of these genes, or specifically BRCA1 and 2, are relevant only to women's cancers, and that may be just because of what's been available in the press, how they were discovered initially, and people's understanding of what cancers they affected. And so I think it's really important to recognize that these genes confer a risk of prostate cancer and are also relevant to men's cancers. So they are not limited, even though they're named breast cancer risk gene, their effects are not limited to breast or even ovarian cancers. So kind of in response to those barriers, we launched this new prostate cancer genetics clinic. And the target population is really patients who have a diagnosis of prostate cancer and one or more of the following: a family history of prostate or other cancers, early diagnosis, less than 60 years old, especially with aggressive disease, Gleason 8, 9, or 10, or metastatic disease, any known mutations for cancer predisposition, such as BRCA1 or 2, Lynch syndrome, P53, male breast cancer, anyone who has undergone tumor sequencing with findings that might suggest that they have a germline mutation. I didn't talk as much about that, but there can be suggestion on tumor sequencing that that's the case, and if they want follow-up guidance or counseling, that would be appropriate. Any prostate cancer patient who wants to learn more about genetics and how it may be important to his care. The services that we've been providing, information, education, you can hopefully appreciate from the talk today that this landscape is changing very quickly, and it's hard to stay up to date. So just sort of updating patients as well as providers about what the recent findings and developments are. We do coordinated genetic counseling and testing. There is a genetic counselor in clinic at all times that sees all our patients to review findings if they were already provided, or to coordinate testing moving forward, and to assist with insurance considerations as well. Also, we can refer family members for screening prevention of other types of cancers. We have a number of clinical trials, family studies, and registries that are available to patients to help move the field forward. We also have access to cutting-edge therapeutic clinical trials as well as early detection and of cancer trials as well. So those are reasons why it might be helpful to send patients that meet some of these criteria to our clinic. So I'm going to wrap up by going over the take-home points. It's important to obtain a thorough family cancer history. This is really critical. To remind you, ask both about mother's side of the family, father's side of the family, all cancers, if possible, age of onset, treatment, and whether or not that cancer was a cause of death. The second point is that more than 10%, really close to 12% of men with metastatic prostate cancer had inherited cancer risk genes in genes such as BRCA2, BRCA1, and ATM. And importantly, these findings were in a group that were unselected for family history. If you account for family history, I suspect that proportion will be even higher. Patients with metastatic prostate cancer may benefit from genetic counseling regardless of their family history. This is the metastatic population. But certainly if you have a family history or you find a family history in someone who has prostate cancer that's not metastatic, that would still be appropriate for consideration of counseling. Men carrying an inherited BRCA2 mutation and who are diagnosed with prostate cancer have more aggressive disease. There are new treatment options for these men, clinical trial options for patients who have prostate cancer with these mutations, both those who are inherited and those who are tumor-only DNA repair mutations. And discussion about prostate cancer screening and early detection vis-a-vis PSA, digital rectal exam, consideration of pelvic MRI even, should really factor in family history of prostate cancer and all cancers. Someone who is at high risk based on, for example, having a BRCA2 mutation in the family should really factor that into the discussion about whether or not to proceed with PSA screening and so forth. So those are the main points I have for you today. I thank you for your attention. Welcome any questions. This is my email. Feel free to reach out to me if you have any questions. This is the number for the Prostate Cancer Genetics Clinic or any other questions you may have. Thanks so much and have a good rest of your day.